Right. I hope your correct slides will appear. So we're going to now move on to talk about HPV in a slightly different context from the talk that you've just had. But maybe it's, I hope it's some of the good news, because it's some of the things that Colm has described and the developments that there have been. And I think what we're going to hear this afternoon is that there really are developments in HPV. It's been one of the areas of STIs where we've made the greatest progress in the last few years. And the first part of this is to have some discussion about the HPV vaccine program in MSM. And so I would like to thank and welcome Kate Soldan, who is consultant epidemiologist from Public Health England, who works particularly on the evaluation of the HPV vaccine programs and also the National Chlamydia Screening Program. And she's going to talk along with Marta, Checchi, who is also here. They're going to do a double act and cover this aspect, and then we'll move on to talk about some other things to do with HPV afterwards. So thank you very much, Kate.
Thank you, Richard. Hard act to follow. It's never been truer than today, but I'm very pleased to say good afternoon. And with my colleague for the next 20 minutes or so, we're going to talk to you about the MSM HPV vaccination program, also putting it in a bit of context with the female program. So we want to cover for you as an overview and any questions at the end. The rationale for the program, many of you may be familiar with that, but we'll go over it at its introduction when it was first designed, and just refreshing that now given what's happened since it was introduced. We'll also talk about the progress of the program so far and the progress of the female program in parallel as a sort of the context of the epidemiology of HPV due to vaccine introduction, and what we've learned about how it's working to date, and more about how we will evaluate this program in the future. So I'm grateful to all of the colleagues here for the content of this talk, and Mark Jitt presented some of this work at IPV in Sydney. If you've seen it before, that might be where. So to give you a bit of background, as has been mentioned, HPV vaccination for adolescent girls was introduced to routine age of 12 back in 2008. And there was a catch-up program then until the age of 18. Then in September 2012, as Colin mentioned, the vaccine changed from the cancer-preventing vaccine to the cancer and warts-preventing vaccine in the national program. Then moving on, in November of 2015, the JCVI had reconsidered the issue of MSM, given that boys were not included in the adolescent program, and it was recommended there, based on some work that I'll show you later, that this became rolled out. And it started with a pilot program in England and programs in Scotland and Wales in June 2016. And in February 18, it was announced that that pilot program had been successful, and following Scotland and Wales go to a national program, England will go to a national program starting from April 18 in a phased rollout, and we expect that to be complete rollout by April 19. And then in the most recent news on the HPV vaccination front, I guess, is in July 2018, it was announced that the adolescent program, this one that started in 2008, would now change to include all males as well. So male boys of 12 to 13 years of age in school will be offered the vaccine as well. So that's the context for the MSM program. The rationale for it, you will know, of course, that MSM are at greater risk of HPV-related cancer, of HPV infection and of warts, but particularly of HPV-related cancer. And this is to some extent driven by HIV positivity, but also driven by behavioural factors and ongoing exposure to infection throughout the lifetime, which is slightly different to females. Sites of the cancer are different. Obviously, cervix is the main driver for females, but these cancer sites have been shown to be higher in MSM, particularly anal cancer as being the most important driver for the use of vaccine. And in some of these studies, the knowledge of sexual orientation is limited, but in HIV-positive studies, it's been well known, and so the risk there, as you can see, is really very much raised. The number of cancers per year in men and in MSM is shown there on the right. So the number of cancers is relatively small compared to cervical cancer, but of course the population group much smaller. So this was showing a much higher risk, particularly of anal cancer in MSM. And as these men were not going to be affected by herd immunity through sexual contact with vaccinated women, this was clearly a remaining area of HPV infection that needed to be addressed. Showing the cancer data slightly differently for anal cancer, to make just a couple of points here. The age distribution is different to cervical cancer, so cervical cancer hits women much younger, anal cancer is older, and in fact there is a large number of cases over 74 as well, and that affects the quality of life losses that you get with anal cancer. But the numbers here, and you see the rates in HIV positive MSM are really much higher than they are in cervical cancer, and so all these data, along with the vaccine efficacy data, was fed in to the mathematical model that informed the program. The other aspect of whether this could be done as a public health intervention was where and how it could be done. And so, fortunately, in England, it was known that a large proportion of MSM did attend sexual health clinics, the clinics you work in, and HIV clinics. And particularly, so here you see about 30% of HIV negative MSM have attended a GUM clinic, and almost 100% of young HIV positive men. So there is the opportunity there to give this intervention to a high proportion of the population at risk. Then the question was, well, is it too late? Have men already been exposed and there's no longer any benefit from vaccination if you take this opportunity of going to clinic and offering a program there? So a study was done in Richard Gilson's department by Eleanor King in collaboration with us to look at the HPV prevalence in men attending a GUM clinic in central London, the Mortimer Market Centre. This was really important work, and it showed, as you can see here, the prevalence of HPV and high-risk HPV was high. And of the quadrivalent types and of the bivalent types, it was high. But have I got a pointer here? Oh, sorry. Yeah. So here it shows you that, however, 81% did not have any of the bivalent types at the time of sampling, and about 67% did not have any of these 4 types. So a large number did not have a current infection. And in fact, this study, not published in this paper, but also looked at seroprevalence. And so we know from this study that over 50% had neither current infection nor seroprevalence. So there is a large number still unexposed and with a lot to benefit from vaccination. The other key thing this showed was that the age, these are age groups along the bottom, so increasing age, this is the risk of acquisition continued to be high, well up to 30 at least, and then remained high, although not increasing after 30. So unlike in women, the risk of exposure, so the time of potential to give the vaccine to intervene goes much later in life, can be beneficial much later in life. So mathematical models are great at combining this kind of data to give an outcome of how much you can benefit if you do give an intervention like a vaccine. And so here you can see, well, genital warts is not shown here, but the model predicted a 35% in genital warts in 5 years of vaccinating in GUM clinics, and a 55% drop in anal cancers in 100 years. So it goes from 45 down to 20 over about the first 50 years. So this was substantial benefit, really, from introducing the program. Adding in the cost and quality loss that you can prevent and the cost of giving this, it was found that, just to focus here, really, in the interests of time, that if the vaccine cost was 48, or in fact if it was less than about £60 per dose, then it was cost effective, and the best option was to give to all 16 to 40-year-olds, not just HIV positives, but all men, MSM, 16 to 44-year-olds. The study showed that this was sensitive, mostly to vaccine price, but also to warts quality of life and duration of that quality of life through to warts. But given all of those sensitivities, this was really quite a robust finding. And therefore, this was all presented to JCVI. I'll do these in a different order. And JCVI in November 2015, after reviewing that epidemiological evidence on the economic modelling of it, decided that it would be appropriate that could it be delivered cost effectively, so under the £60 for buying and giving, then it should be offered to MSM in the UK. And Marta will come on to talk about how that is, the progress that we've made with that. Just wanted to do one more slide about the sort of rationale, because coming back to the fact that in 2018 it's been announced, so the program's been running for 3 years, but it's been announced that all boys will have vaccination quite soon. But it remains, this doesn't really affect the rationale for the MSM program, is the point I wanted to make here. So some MSM, well, first of all, the age, as I showed you, the age of exposure, the program goes up to 45, and those men will not be captured by the adolescent program for many years until 2050. Some may miss out, people who move into this country or are not in school, and really the higher risk in MSM does justify this program continuing even with the adolescent program starting. So that doesn't change the scientific rationale for doing this program. So I'll hand over now to Marta, who's going to talk to you about the progress that's been made with the program so far and how we're planning to evaluate it.
Thank you. Right, so I'll just take over now and go through some of the progress to date and highlight some results thus far and some future surveillance plans. So as Kate mentioned, the implementation of the JCVI recommendation in England started with a pilot program which ran from June 2016 to April 2018. And the pilot has now been followed by a phased national rollout of the program from April of last year. So the pilot involved 42 clinics across England, 17 of which were sexual health clinics, 4 HIV-only clinics, and 21 of which were both sexual health and HIV clinics. A project board involving PHE, NHS England, and the Department of Health and other key stakeholders has been running since before the start of the pilot to oversee implementation of the vaccination program for MSM, and this has been especially critical for arranging commissioning. So as per the JCVI advice, clinicians can offer vaccination to other patients on a case-by-case basis if they deem them to fall under a similar risk profile. So this includes some MSM over the age of 45, sex workers, HIV-positive men and women, and some transgender women as well. So we have a number of ongoing surveillance activities at PHE to monitor the impact of the HPV vaccination program, both in MSM and in females, and these focus on 3 main areas. So I'll go through each one, highlighting results or upcoming surveillance plans. So the first is vaccination uptake and coverage. So for MSM, this is being carried out using GumCAD and HARS national surveillance data to analyze uptake and attendance patterns. And uptake estimates will also be verified by carrying out a seroprevalence study that will test residual serum specimens from MSM attending for HIV or syphilis testing for HPV 16 and 18 antibodies. So as I mentioned, uptake of HPV vaccination in MSM is being monitored via our existing surveillance systems for sexual health and HIV clinics, GumCAD and HARS. So the data shown here is for the full pilot period, which covers approximately 2 years. As the first pilot clinics began implementation, you can see here in June 2016. And as you can see in the figure, however, the majority of clinics did not actually begin implementation until the last quarter of 2016. So overall uptake during the pilot was approximately 50%, with some clinics achieving over 80% uptake, actually close to 90% in some cases. And recorded refusals have been very low at only 3.5%. We do, however, know that there were some issues with incomplete data recording at some clinics, and we therefore believe that these uptake figures may be slightly underestimated. So we had a closer look at the data recording issues during the 2-year pilot, and as you can see in this figure here, the first blue bar shows the proportion of MSM vaccinated with the first dose at just under 50%, and refusals in green at under 5%. Sorry. So we see in this third bar that almost 50% had no HPV vaccination code. So this could be due to a number of reasons, ranging from some clinic staff not offering the vaccine from the start date, or incomplete use of new codes for reporting both offering or administering vaccination, or software changes at some clinics. So we do need to make sure that this improves during rollout of the national program, which is now underway. So we're aiming to target these issues, and one of the ways we're looking at doing this is via some training webinars. But we also ask that you take this message back to your clinics to stress the importance, really, of data recording to properly monitor the vaccination program. So using the pilot data, we also started to look at second and third dose completion among MSM who had received a first dose. So we have seen that approximately 60% completed their second dose and 30% completed their third dose. So the data shows that second and third dose completion are accumulating on track with the clinically recommended vaccination schedule, which is for 3 doses to be administered ideally within 1 year, although a 24-month period is clinically acceptable as well, with the second and third dose given at least 1 month and 3 months after the first or second dose. So this actually means that final completion rates will not be known until those who started the vaccination course have been followed up for 24 months. Not shown on this figure is that we have seen some evidence of missed opportunities within the pilot, with approximately 20% of MSM who received a first dose attending within the recommended interval, but not actually receiving their second dose. So to verify uptake estimates from GumCAD and HAR surveillance systems, we're planning to carry out a seroprevalence study, as I mentioned, in MSM attending sexual health clinics for syphilis or HIV testing. And we'll do this by testing residual serum for type-specific HPV DNA. So we've actually carried out similar surveillance in females, and this figure here outlines results from that serology work. So in females, we found that serological surveillance does confirm high vaccine coverage of the female HPV vaccination program, particularly in the youngest ages. So the proportion of females with vaccine-induced seropositivity was actually slightly lower than the reported 3-dose coverage for 15 and 16-year-olds, but higher at the older ages. So this suggests that 3-dose coverage in the catch-up cohorts could be higher than reported, or that 2-dose coverage could be associated with higher antibody responses. So we also looked at the potential impact of targeted vaccination for MSM on services, and we did this by looking at GumCAD data from January 2009 through to the end of the pilot. And to see whether attendances of MSM had increased at pilot clinics, we looked at patterns of attendance both pre- and post-pilot introduction in June 2016. So we know that MSM attendances at sexual health clinics have been increasing over time, but we found that attendance patterns did not deviate from these expected trends and variations. And that was both in terms of overall numbers as well as in the proportion of MSM attending from outside their local authority of residence. So I've covered the vaccination uptake strand of our evaluation plan, and the second is to measure the impact of vaccination on the epidemiology of HPV infection in MSM. So this will be done by conducting type-specific HPV DNA testing of residual rectal swab samples collected from MSM attending GUM clinics for chlamydia testing. So this is being done, as I said, by collecting residual rectal swab samples from MSM up to and including 45 years of age, attending sexual health clinics for chlamydia testing, and these will then be tested for HPV subtypes. So we're planning on doing this via a phased approach, and phase 1, which is almost complete, is the collection of samples from a largely unvaccinated population of MSM to estimate a baseline type-specific HPV prevalence. And this is going to allow us to compare HPV prevalence in unvaccinated MSM receiving their first dose with those not offered or refusing the vaccine, as well as because we're able to link to vaccination status using GumCAD data. And phase 2, which is expected to start at some stage next year, will collect samples in a post-vaccination period in order to compare the HPV prevalence in fully vaccinated MSM to unvaccinated MSM. And we'll also be able to estimate HPV prevalence in partially vaccinated MSM as well. So in total, we are collecting almost 4,000 residual rectal swab specimens from 7 sexual health clinics across England. And as of the end of 2018, our lab has tested approximately 1,000 specimens from 5 sexual health clinics. And these are some very preliminary results here. So just under 1,000 specimens had an adequate result, 36 of which were found positive for either HPV 6, 11, 16, or 18, which are covered by the quadrivalent vaccine. 22% were HPV 6 or 11 positive, 20% HPV 16 or 18 positive, and very few, you can see here, were found to be both HPV 16 and 18 positive. So these results are actually quite similar to the data that Kate was showing earlier from previously published data from a study conducted at Mortimer Market. Now, among the almost over 900 specimens from 5 sexual health clinics that we've had adequate testing results for and age data available, we looked at the breakdown of HPV 16 or 18 prevalence by age group. So as you can see from this figure, we don't see any major variations by age group in HPV 16 and 18 prevalence, though it does seem to be slightly lower in MSM under the age of 25. So again, just to stress that these are very preliminary results. Once the testing is complete, we will be conducting more in-depth analyses. So we conducted similar surveillance in females, collecting residual vulvovaginal swabs from females attending for chlamydia screening to test these for type-specific HPV DNA, both pre- and post-vaccination. So these are some results from that surveillance. And these figures depict the changes in post-vaccination prevalence of HPV 16 and 18, as well as HPV 31, 33, and 45 by year of birth in both England and Scotland. So the first females would have been eligible for HPV vaccination would have been born on or after the 1st of September 1990. So as you can see, the prevalence of HPV 16 and 18 has declined dramatically in females who would have received the vaccine. Declines were also seen in the prevalence of HPV 31, 33, and 45, though these were perhaps not as dramatic as HPV 16 and 18. So the final element of our evaluation plan for MSM is to measure the program's impact on early disease outcomes. So this will be done by analyzing routine GumCAD surveillance data on first episode and recurrent genital warts diagnoses. So to date, we have conducted surveillance of genital warts in young females and males to monitor the impact of the female vaccination program on early disease outcomes. So this graph here depicts the rate of genital warts diagnoses per 100,000 population from 2009 to 2017 in females, heterosexual males, and MSM. And on the second axis, we have female vaccination coverage for both the bivalent vaccine in the lighter gray and the quadrivalent vaccine in the darker gray. So as you can see, up to 2014, females in this age group would have exclusively received the bivalent vaccine as part of the national program. So we don't start to see an impact of the quadrivalent vaccine until after 2014. So we start to see very substantial declines here between 2014 and 2017, which can be attributed to quadrivalent vaccination. So in the 15 to 17-year-old females, there were declines of over 80% during this time period, so quite substantial. And we also saw similar patterns in same-aged heterosexual males, almost 70% declines, which suggests there's a strong evidence for herd protection. And we also saw some small declines in MSM, so approximately 15%, though numbers in that group are still small in the younger ages. So to measure the impact of targeted vaccination for MSM, we plan to monitor both first and recurrent episodes of genital warts diagnoses, and we'll be able to link that to vaccination status using GumCAD data. So to conclude, data from the HPV MSM pilot has shown that implementation of vaccination had no effect on MSM attendances at sexual health clinics. And we also didn't see any important variations in uptake by age, HIV status, or geographical area of residence. And despite some issues with data recording, completion rates are increasing, though we have seen some evidence of missed opportunities that will need to be addressed during the rollout of the national program. And the impact of targeted vaccination for MSM on genital warts diagnoses is still too early to report, though we will start to look at this from this year. And a baseline collection of rectal HPV prevalence is almost complete, and more in-depth results there will be reported later this year. And finally, evidence from the HPV-MSM pilot has therefore shown that targeted vaccination for MSM can be delivered opportunistically in an acceptable and equitable manner via sexual health and HIV clinics, which actually supported the decision to proceed with national rollout of the national program last year. Just to acknowledge our colleagues at PHE. Thank you.